I'm going to basically try to cover today some aspects of the routine cardiac surgery care. I'll talk about management of post-operative complications, and I'll talk about cardiac arrest after cardiac surgery. So most of you have done a CSRU rotation, and you'll notice that our handover, it follows that COLD acronym. You connect first, you observe, you listen, and then you delegate. Basically, you assume care from the anesthesiologist and the perioperative care team once you've received your handover. And during your handover, you want the handover to happen during a period of stability. You don't want to be, pushing phenylephrine and then, somebody walking out on you and telling you you're happy to take over. You'd like some state of stability before you get handover on your patient. Essentially, what you need to hear about is obviously captured in our admission sheet, information related to the patient, how they presented, what their comorbidities are, what medications they're on, their allergies, whether they had an echo, and what was their angiogram findings. You want to hear a little bit about the surgery, and the surgeons will tell us about their pump time, their cross clamp time. And then you want to hear about anesthesia, how much heparin, how much protamine was given, any problems with anesthesia, hemodynamics, coming off pump, and all that. In the first 4 hours, we usually target a systolic of 90 to 120. And the reason is basically it's because the suture lines of the surgery itself, you don't want to test the suture lines by very high blood pressures. Beyond 4 hours, you can loosen your targets a bit, up to 140, sometimes even higher. But during the first at least 4 hours, and especially if they're bleeding, you really want tight systolic blood pressure parameters. ASA is given usually at the 6 hour mark, especially if they have saphenous vein grafts. And so what's the reason we want to give ASA early? It really does help with saphenous vein graft patency. So if they've had a CABG with a vein graft, you really want to give the ASA at the 6 hour mark. So if they're extubated, give it orally. If they're still intubated, you can give it rectally. Obviously, you can hold ASA if their platelets are less than 60 or if they're bleeding. Post-op day 0, you're usually expected to check the chest x-ray for lines and tubes, check the blood work, the ECG. Antibiotics, they usually get cefazolin 1 to 2 grams IV Q8 hours for 24 hours, or Vanco if they're allergic to penicillin. And during that first post-op night when you're on call in the unit, the thing that you get called most about is usually low blood pressure or low urine output. And so you typically want to watch for end organ perfusion, what their lactate's like, what their urine output's like. You will likely need to give a little bit of IV fluid during the first post-op or the post-op day 0 because of the systemic inflammatory response that you get from being on cardiopulmonary bypass. You also want to watch for excessive bleeding, hypothermia, electrolytes, specifically hyperkalemia. We all know that cardioplegia is very high in potassium. And once they start recirculating their cardioplegia back into their circulation, they can get quite hyperkalemic. And so you want to watch for that. And once they're extubated, you'll be looking at pain control as well. Extubation is usually done on a fast track basis. You only need an SPT for about 30 minutes or so before they extubate. You need to make sure that they're awake and their blood gases are acceptable. Post-op day 1, we usually start beta blockers. Metoprolol is what we usually start. What's the reason we give beta blockers? What's the reason I'm asking about beta blockers on RAMS? Really, the main reason is AFib prophylaxis. It's been shown over and over again that the most effective intervention to prevent post-op AFib is early and aggressive administration of beta blockers. So I'll sometimes start beta blockers post-op day 0. If I'm rounding at night and they've got a high blood pressure and they're extubated and they've got a good heart rate, I'll typically start them on post-op day 0 and ramp it up by post-op day 1. By the latest, they should be on a beta blocker by post-op day 1 if they are not on pressors. Regular ASA and DVT prophylaxis, you usually dangle these patients, have them sitting at the edge of the bed and having that sort of dump from their chest tube happen first before you lay them back and take the chest tubes out. And then you get a chest x-ray after removing the chest tubes for pneumothorax screening. Good. So one of the questions I had, what are the benefits of early mobilization in the ICU? You'll notice we focus quite a bit on this in CSRU. Have they been up? Have they been in a chair? List 4 demonstrated benefits for early mobilization, early physio in the ICU. The big ones that were shown in a publication in the Lancet where they randomized patients to actually early physiotherapy versus standard of care, they basically found that it reduced the rates of delirium, and these all had statistically significant p-values. It reduced the mechanical ventilation days and hence the actual ICU length of stay. It reduced the incidence of critical illness myopathy, and it increased the rates of return to independent functional status. So these are definite benefits from early mobilization in the ICU. The study was not a cardiac surgery study, but I think the results do make sense and would be applicable. So post-op day 2, you would look at potentially fluid mobilization. They've gone beyond their SIRS response from cardiopulmonary bypass, and now they're mobilizing fluid back into the central circulation. If they're requiring high FiO2s or they're on excess, supplemental oxygen, then you may consider giving diuretics to improve that fluid mobilization. Getting them up and out of bed is usually very helpful. All right, so I'll talk a little bit about certain surgeries and certain specific considerations for certain cardiac surgeries. I'll skim through a few, and then we'll go into the complications. Stop me at any time if you have questions or comments. The first surgery I'll go through is cabbages, and by far the most common procedure that we're doing here are cabbages. We typically will do them for significant coronary stenosis. And I will not ask this question because I know there's cardiac surgeons here on the phone. So what is the degree of coronary stenosis that is considered significant? And so you consider coronary stenosis significant when it's a left main disease that's greater than 50% occluded, or one of the 3 major vessels that's greater than 70% occluded. Now, standard of care for left main disease is to do a double bypass, is to bypass both the LAD and the circ. So the 2 branches of the left main are usually bypassed if you have left main disease. All right, aortic valve replacement. What's special about aortic valve replacements in the post-op period? They're very preload dependent. So what happens is they've got long-standing aortic stenosis, they've got LVH, they've got non-compliant ventricles. They like their preload. They want the extra fluid on board to keep their ventricles full. And so you'll end up giving quite a few fluid boluses to these patients post-op day 0. And you'd like them to stay in sinus rhythm if at all possible, because they like their atrial kick given that their ventricles are so non-compliant. Post-operative heart block is very common. The suture line will sometimes interrupt the conductive pathway. You can get either left bundle branch blocks or complete heart blocks with aortic valve replacements. The incidence is close to 5% or so. So I'm talking about surgical aortic valve replacements. There is a high incidence of getting AV block. All right, mitral valve replacement. What considerations do you have for a patient coming post-op day 0 after a mitral valve replacement? Well, essentially it depends on the underlying pathology. Why did they get their mitral valve replaced? Was it because of mitral stenosis or was it because of mitral regurg? So with mitral stenosis, it tends to be more of a back pressure issue. Their pulmonary circulation is congested. They start to develop pulmonary hypertension. They'll sometimes start to develop RV failure and may need some degree of RV support. So with mitral stenosis, they'll also sometimes be on diuretics in the long run to avoid going into CHF. So that's one consideration for mitral stenosis. What about mitral regurgitation? Mitral regurgitation, the problem tends to be more the left side of the heart as opposed to the right side. And so what usually happens with mitral regurg is that there's a pop-off valve now. You've got a regurgitant, you've got an incompetent mitral valve, and the ventricle is pumping against the low pressure of the atrial system. And all of a sudden, you fix that valve and the ventricle is forced to pump ahead into a high pressure system, the aortic valve and the systemic circulation. And so once you close that pop-off valve, the left ventricle can sometimes take a little bit of a hit. And you can get a bit of a drop in LV function because you've basically sealed that pop-off valve and the LV is now all forward flow, no low pressure backward flow. And so with MR, if they go in with an EF of 30%, then I typically will get inotropes ready to come off pump, because they'll likely get a little bit of a drop in their EF coming off pump. So requiring a little bit of LV support is not unheard of after fixing mitral regurgitation. Next, I'll move on to another rare complication, but if you see it, you'll never forget it. So with mitral valve replacements, one devastating complication that can happen is AV groove disruption. Now, when does this happen? It happens when the mitral annulus is extremely calcified and the surgeons are suturing that new mitral valve against a very calcified annulus. You can start getting, especially in elderly females, that tends to be the demographic that's affected, more friable tissue. What can happen, and this can happen either in the OR or in the immediate post-op period, and I've seen both. They can develop a bit of a dehiscence of the posterior part of the heart, what we call AV groove disruption. And how it presents is blood, blood, blood. In the OR, essentially you'll see blood pooling up in the chest, and the surgeons are trying to find where it's coming from. At the end of the day, it's likely coming from the back of the heart. If you're in the ICU, then they'll be behaving themselves until all of a sudden you get a huge dump and they lose pressure. The next thing you know, you're doing CPR. So it's a pretty rare complication, but it's not unheard of. I've certainly seen it. And the mortality is pretty high. It's, depending on the reports you read and the techniques for surgical repair, it's anywhere from 25 to 70% mortality. So that's a complication that, is pretty devastating. You really need to be on top of it once it's discovered. And these patients, if they're in the ICU, will need to be rushed back in the OR for surgery, sometimes while doing CPR and having a level 1 hooked up. And typically they'll come back with an open chest, and it'll be, the whole works. They'll get a delayed closure after and everything else. All right, next, I'll talk a little bit about mitral valve repair. We've talked about replacement. Mitral valve repair, on the other hand, is associated with a complication that we've all heard of, and that is SAM, systolic anterior motion, or dynamic LVOT obstruction. If you have a long anterior mitral valve leaflet, and they repair that mitral valve by, say, putting in an annuloplasty ring, so now you've got a tightened annulus, and you've already got a long anterior leaflet that's a little bit redundant. And especially if you have a little bit of LVH and a narrow LVOT, you can get flow acceleration through that LVOT and SAM. So with mitral valve repair, what you really need to watch for after coming off pump in the OR, and if they develop instability in the ICU, you want to watch for SAM. Why are they unstable? Is it because of SAM, or is it because of something else? So how do you treat SAM? So essentially, the important thing to notice in patients, if you were to diagnose SAM, usually these patients will have, if you're in the CSRU, for example, they'll have some degree of a lowish blood pressure, and you're trying to find why they've got a lowish blood pressure. You put in the TE probe, and lo and behold, there's SAM. These patients, if they've got a low pressure, are usually on some degree of inotropy, whether it be levo, norepi, or epi. Norepi will have some sort of beta, maybe 10, 20% of its action is beta, mainly alpha though. But they will be on some form of inotropy. And once you diagnose SAM, the important thing to recognize is inotropy is not helpful. Get them off whatever they're on in terms of inotropy. Go with afterload increase, filling the tank with volume. And so essentially what you'd want to do is first fill the tank up, make sure that their LV dimensions are at the maximum they can be. Essentially, why does flow acceleration happen? Is because you've got a narrow LVOT and a redundant anterior leaflet. And so when you think of it, the way you want to treat this is make that LV bigger as much as you're able to increase that LVOT diameter so that they don't get flow acceleration, so that their anterior leaflet's not entrained into the LVOT. And so how do you make their LV bigger? Well, you fill them up with volume. It can increase their afterload purely by alpha. Something like phenylephrine or vasopressin is probably a better idea than epi nor epi. You can slow their heart rate down by beta blockers. I typically try esmolol before I jump on any beta blockers in a hypotensive patient, because beta blockers can really tank your pressure. Esmolol is a forgiving drug. It'll last you for 5-10 minutes, and then it'll go away and you're back to where you started. So if you want to try beta blockers, I'd start with esmolol 0.5 per kilo bolus, see how that affects your hemodynamics, and if it's favorable, then you can switch to something more long-acting like metoprolol. Or you can run an infusion of esmolol. So essentially, that's how you treat it. Intravascular volume expansion, discontinue the inotropes that they're on, increase afterload either by phenylephrine, or even if you're in the OR, manual compression of the aorta will increase your afterload. The surgeons can do that. And the last thing is beta blockers. If all that fails, then it'll be surgical revision. Now, what's your thoughts about conservative management? Will it be successful in these patients or will it not? What are your thoughts? How often would they require surgical revision, do you think? So medical management tends to work close to 90% of the time. It'll be the standard medical management that'll likely get you where you want to be. So success rate with conservative management is 85, 90%. So that's important to note. Let's move on to another type of surgery and a unique complication that you may see with minimally invasive cardiac surgery. This is sort of rapid fire, just sort of, each surgery and what to expect, because we'll get into the complications shortly. Like the generic complications. These are sort of more specific complications to specific procedures. So minimally invasive cardiac surgery. Minimally invasive cardiac surgery are what we call mini mitrals. So basically, these are surgeries where they go through a right mini thoracotomy, do a mitral valve repair or replacement. There's also off-pump cabbages that can be done through a left mini thoracotomy. So these are also considered minimally invasive. I'd say minimally invasive cardiac surgery is a bit of a misnomer because it's a maximally invasive surgery through a small incision. But regardless, I think mini mitral is has a very nice ring to it. They do go on pump and the full works, so it's not as minimally invasive as you think. Regardless, the incision of a thoracotomy is probably better than a sternotomy on the long run in terms of sternal stability and stuff, although they do tend to have significant pain still. So what complications can you get from minimally invasive cardiac surgery? Sometimes you'll get unilateral atelectasis or pulmonary edema. Sometimes you'll get excessive pain because of thoracotomy. Thoracotomies are quite painful. Sometimes I'd say more than a sternotomy in the short term at least, and they can get chronic pain from thoracotomies as well. And so unilateral pulmonary edema is a bit of a unique entity that can happen after minimally invasive mitral valve replacements. As I said, they usually will do a right thoracotomy. The right lung will be down during surgery for access to the heart to do their surgery, and they'll be on pump. And because of mitral valve pathology, they'll likely have some degree of pre-existing either pulmonary congestion or pulmonary hypertension. So that concoction in and of itself can lead to the right side of the heart, the right lung specifically, taking a bit of a hit post-op. And so post-op day 1, you see here that the pulmonary edema is pretty unilateral. And this, as I said, is related to being on pump, having mitral valve pathology, and one lung ventilation likely. And then they start to get better, usually with time. Post-op day 3, post-op day 5, they start to get better with time. It usually resolves, but it's a unique complication that you may see with minimally invasive mitral surgery. How do you treat it? Regularly, like you would treat pulmonary edema. Diuretics are usually the mainstay of treatment. If it's really severe, you may consider putting in a double lumen tube and basically protect the other lung from getting involved. I find diuretics is probably the way to go. There are case reports out there of this type of complication requiring ECMO. All right, another specific sort of surgery where certain complications can happen is transcatheter aortic valve insertion, or TAVIs. And so TAVIs have really taken off as a safe alternative to surgical aortic valve replacement, or what they call now SAVR, because now we have to call it something different. So TAVIs versus SAVRs. So TAVIs, the pathology is the same, really, with aortic stenosis. They're preload dependent. They've got LVH. Post-op complete heart block remains common. It's actually a little bit more common than surgical aortic valve replacements, up to 20%. It does depend on the type of valve, though. Like there are newer valves that don't give you that complication as often. But the quoted incidences up to 20% may require permanent pacing after TAVIs because of a complete heart block. We usually don't give prophylactic beta blockers for the first few days because of that. We're waiting for that aortic valve to slowly expand with time. As they deploy that aortic valve in the OR, you'll sometimes find that this anesthetist will tell you there was a paravalvular leak, but we think it'll get better with time. What they mean is that aortic valve will actually expand a little bit with time, and as it expands, that paravalvular leak will get better. But it also, as it expands, the patient may develop a complete heart block from that expanding annulus. And so that's why we try to avoid giving beta blockers in these patients for at least the first 4 or 5 days. We used to discharge these patients to the ward with a transvenous pacer. We're not doing that anymore. They are being monitored on telemetry. The newer valves have a lower incidence of complete heart block. If you were to do a valve through valve, for example, like they had a previous valve and you're doing a TAVI through the previous valve, then you don't need to be worried about complete heart block because they've got that annulus, protecting, I guess, the conduction system. So we don't send them up with transvenous pacers anymore, although we used to do that. Post-op AKI is a common because of the dye load and because they usually have quite a few comorbidities.